Breast cancer is one of the most common cancers in the world, and one of the great success stories of modern treatment. Survival has climbed dramatically over the past few decades. A big reason is that doctors stopped treating it as one disease. Under the microscope and at the molecular level, breast cancer is really several different diseases, and knowing which one a patient has completely changes the treatment. The moment breast cancer is diagnosed, the tumor tissue is tested for 3 key markers, and the results decide everything that follows. The first 2 are hormone receptors, for estrogen and progesterone. The third is a protein called HER2, which, when there's too much of it, drives the cancer to grow aggressively. Whether a tumor has hormone receptors, has extra HER2, both, or none of them sorts it into subtypes that respond to completely different medicines. This is precision medicine in everyday practice. The same test result that names the cancer also points to its treatment. So here are the main subtypes. Hormone receptor positive breast cancer is the most common. It's fueled by estrogen, which sounds bad but is actually a gift, because you can block that fuel. The HER2 positive type is driven by that overactive HER2 protein. It used to be one of the scariest diagnoses, and it became one of the most treatable once drugs that specifically target HER2 arrived. And then there's triple negative breast cancer. It has none of the 3 markers, which means the targeted and hormonal drugs don't work on it. It tends to be more aggressive and more common in younger women, and it's treated mainly with chemotherapy, now increasingly combined with immunotherapy. Same organ, 3 very different diseases. Whatever the subtype, treatment usually starts locally, with surgery. This ranges from a lumpectomy, removing just the tumor and a rim of healthy tissue around it, up to a mastectomy, removing the whole breast. One of the most important findings in cancer history is that for many women, a lumpectomy followed by radiation gives survival just as good as removing the entire breast. That spared countless patients the disfiguring surgery that was once standard. Surgeons also check the nearby lymph nodes, because whether the cancer has reached them is one of the strongest signals of whether it has begun to spread. Then comes the systemic attack, tailored to the subtype. For hormone receptor positive cancer, the workhorses are drugs that block estrogen, tamoxifen, or a class called aromatase inhibitors. Patients often take these as a daily pill for 5 to 10 years after their main treatment, and that long tail of hormone blocking is a big part of why recurrences have dropped. For HER2-positive cancer, antibody drugs, the best known is trastuzumab, sold as Herceptin, lock onto the HER2 protein and shut its signal down. When those drugs arrived, they turned one of the worst breast cancer subtypes into one of the most survivable. It's one of targeted therapy's clearest wins. The throughline for breast cancer is test, then treat. The tumor's biology is read first, its receptors, its HER2 status, sometimes a genetic test of the tumor to estimate whether chemotherapy will even help, and only then is the treatment matched to it. Combine that with early detection through mammogram screening, which finds many cancers while they're small and curable, and you get the reason survival keeps climbing. Breast cancer is, in a real sense, the template for everything precision oncology is trying to do everywhere else. As always, this is educational, not medical advice. Screening decisions are a conversation to have with your own doctor.